So let's start with acute inflammation first. So in that, the first step will be recognition. So recognition is going to happen with the help of certain receptors, which is going to recognize the offending substance. So there is a tau pattern recognition receptors. So toll-like receptor is the one which is going to be present on the plasma membrane. And other than that, we have intracytoplasmic pattern recognition receptors called as nod-like receptors or NLRs. So these are going to identify the pathogen which is going to cause the injury. We also have mannose binding lectins. So mannose is a glucose substance which is present on the sugar. It is going to be present on the bacterial cell wall. So we have certain mannose binding lectins. So these lectins are going to identify these mannose and they are going to attach to them. Then we have collectins and some FC receptors. So FC receptor is going to be present on the, FC portion is going to be present on the immunoglobulin, right? So if this is the immunoglobulin, the antigen will attach at this site, and this is the FC portion wherein complement will attach. So this receptors for this FC region will be there in certain cells. So this FC receptor can identify the immunoglobulin which has come up with the bound antigen. So that is also responsible for the recognition step. Next, what happens in the acute inflammation? So events happening in the acute inflammation will finally lead to the recruitment of the WBCs to the site of injury. So the events in acute inflammation can be classified into vascular events which happens in the vessels and cellular events. So under the vascular events, the first step which happens will be vasodilatation. So suppose this is the normal diameter of the vessel. This vessel will be undergoing vasodilatation, especially in the arterioles, and this is going to be mediated by some vasoactive amines, which are the inflammatory mediators. Okay, so inflammatory mediators like histamine and serotonin, these are vasoactive amines which mediate this vascular events of inflammation. So it will result in the vasodilatation of arterioles, which is the first step. After that, what happens? The dilated vessels are going to become leaky now. So the channels are going to be leaky, and whatever content is present inside the vessel is going to come out of the vessel into the extravascular space. So this is going to cause increased vascular permeability. This again is going to be mediated by histamine and serotonin. So when the vascular permeability is there, when the fluid leaks out of the vessel, the cells leak out of the vessel, what happens? The RBCs present inside the vessel, they are going to be undergoing stasis. So there will be sluggish fluid movement. So blood is going to move sluggishly because water has went out. So with sluggish movement, there is going to be stasis. So these three are the vascular events which happen. So we'll see about the mechanisms which led to this vascular permeability. So starting with endothelial contraction. So endothelial contraction is nothing but the endothelial cells which are like this are going to contract and create a gap between them. So this is the most common mechanism, and it is going to happen as an immediate and a transient response. So for the endothelium to contract, it can happen immediately, but when it has to go back to its normal state, it is going to take some time. So this response is an immediate and a transient response. The second mechanism by which vascular permeability happens is by a direct endothelial injury. So rather than the endothelium moving, the endothelium itself is damaged, and through that the cells can come out of the vessel. So direct endothelial injury can be caused by mild stimulus or a severe stimulus. Mild stimulus example in a sunburn. A sunburn usually takes a longer time to happen, right? So it is a delayed response, but for it to heal, the endothelial injury had happened. So for the injury to be healed, it is going to take some time. So it will be a delayed and a prolonged response. Okay. While a severe injury, like with a microbial toxin, so if there is a microbial toxin causing this endothelial injury or a physical injury, the endothelium is going to be affected severely. So in these cases, again, the response is going to be immediate. So here, this toxin will immediately damage the endothelium, but for the endothelium to heal again, it is going to take some time. So it is going to be immediate but a prolonged kind of a response. So apart from that, when there is any endothelial injury, the inflammatory cells will be recruited to the place, right? So these WBCs which are recruited, they will also come and attach to this endothelium, and they also can produce some amount of injury. So this is the neutrophil which is going to cause some amount of the injury to the endothelium as well. Then the third mechanism is called as transcytosis. Transcytosis is just through the cell without damaging the endothelium. The cell has to pass through. So that is called as transcytosis, and this is going to happen via a organelle called as vesiculovascular organelle. So vesiculovascular organelle is responsible for transcytosis mechanism of increased vascular permeability. Okay, so these three are the major mechanisms which can happen in vascular permeability. Then we'll see about the cellular events. Now that the vessel has dilated, what happens in the cellular events? So normally in a blood vessel, if you see, the RBCs will be going in a central plane, while WBCs will be in a peripheral location. But during margination step, which is the first step in the cellular event, the WBCs which are much more peripheral to the RBCs are going to become far more peripheral, and they'll go near the endothelium. Okay, so if the WBCs were initially present near this RBCs here, they are going to acquire a peripheral location, as in they are going to come near the endothelium. So this is called as margination, which is the first step in the cellular event. Then the next step will be the WBCs which had come to the which had come near to the endothelium are now starting to roll over the endothelium. So they'll have an attachment with the endothelium, and this attachment is not going to be so strong. So immediately with the moving blood, it will be dislodged, and then it will move again. So again it will go and attach to the endothelium, and again it will get dislodged. So this kind of attachment and detachment is going to cause the rolling of the WBC on the endothelium. So this rolling is going to be mediated by certain selectins. So selectins, we have three types, which are L-selectin, E-selectin and P-selectin. So L-selectin, as the name suggests, is going to be present on the leukocytes, and E-selectin is going to be present on the endothelium, while P-selectin is going to be present on the platelet and endothelium. Okay. So the corresponding ligands for this selectins will be expressed by the other cells, and there will be attachment between these selectins and the ligands, which will cause a very mild kind of an attachment leading to rolling. So let's see what are the selectins and their ligands. So this L-selectin will be expressed by this WBC, and the E-selectin and P-selectin will be expressed by the endothelial cells. So the ligand for E-selectin and P-selectin will be expressed by the WBCs. Then that is how the WBC can go and attach to these receptors. So ligand for P-selectin and L-selectin will be present on the WBCs, while the ligand for L-selectin, which has to attach to the WBC, will be present on the endothelium. Right. So when there is this attachment, it is going to be a weak affinity. So the cells will start rolling. They attach, they'll detach, leading to rolling. So remember, selectins are the ones which are going to mediate rolling. Okay. Then comes addition. So addition is the step wherein the WBCs come and have a strong attachment with the endothelium. So the affinity between the endothelium and the WBCs is going to be quite strong, and that will result in the addition step. And addition is going to be mediated by integrins. So rolling is selectins and addition is by integrins. So integrins are present on the WBCs normally. So what are the integrins? The VLA4, LFA1 and MAC1. So these are the integrins present on the WBC, be it a neutrophil or a macrophage. So VLA4 is present on the neutrophil, while LFA1 and MAC1 are present on the macrophages. So they will attach to their corresponding receptors present on the endothelium. So VLA4 will go and attach with VCAM1, which is expressed by the endothelium. Okay. While LFA1 and MAC1 will attach to the ICAM1, which is expressed by the endothelium. So integrins are present on WBCs. They'll attach with VCAM1 and ICAM1 present on the endothelium, resulting in addition. So all of these cellular events are actually mediated by TNF alpha and interleukin 1. So the major inflammatory mediators causing the cellular events will be TNF alpha and interleukin 1. Other than that, we have specific inflammatory markers which will be seen later. The next step will be transmigration or diapedesis. So once this WBC has come and attached to the endothelium, it has to travel past this endothelium. So it will travel past the endothelium and come out of the vascular space. So this is called as transmigration or diapedesis. It is just the passing of this WBC from the vessel through the endothelium into the extravascular space. So and it is going to be mediated by CD31 or PCAM. PCAM1 or CD31 is responsible for diapedesis. Okay. Then the next step is chemotaxis. So once the WBC has come out of the vessel, it has to, from the extravascular space, it has to reach to the site where the offending agent is present. So suppose this was the offending agent, the WBC which has come out has to come to this place. So it is going to be driven to this place with the help of a chemotactic gradient. So chemotactic gradient is going to be caused by the presence by the inflammatory mediators. So because of this injurious substance, there will be inflammatory mediators produced, and this inflammatory mediators will call these inflammatory cells towards that side. So this gradient created by the inflammatory mediators is called as the chemotactic gradient, through which the WBCs reach the site of the offending agent. Okay, and how does this WBCs move towards the site of the offending agent? It is due to the polymerization of the actin. So polymerization of actin will happen in the WBCs, which will cause the chemotaxis. So what are the chemotactic agents which can cause this? These chemotactic agents are the inflammatory mediators which cause chemotaxis, right? So we have exogenous chemotactic agents and endogenous chemotactic agents. So under exogenous, we have the bacterial products. So the bacterial products itself will act as a stimulus and cause the recruitment of the inflammatory cells. Endothelial cells, we have many chemotactic agents, but remember the most common ones, which are leukotriene B4, then interleukin 8, and then C5a, complement 5a. So this you can remember it as LIC. So LIC is the chemotactic agents which are which cause the chemotaxis. So now the second R, which was the recruitment step, is complete. The third R will be removal. Now, WBCs had been recruited to the site. So once they had reached the site of the offending agent, they'll have to remove this offending agent. So this removal will take place with the help of the process called as phagocytosis. Phagocytosis happens under 3 steps again. First will be the WBCs has to recognize this offending agent. So that will be the recognition step. Then it has to engulf this offending agent. So it will engulf and close it. So inside the WBC, inside this phagocytic cell, what happens? Next step will be the intracellular killing. So the offending agent which has been engulfed will be killed inside the cytoplasm of the phagocyte. So let's see one by one. So first step was the recognition. So recognition is going to happen through phagocytic receptors. So we have 3 phagocytic receptors. First one will be mannose receptor, which is going to bind to the mannose which was present on the bacterial cell wall. Then we have scavenger receptors and receptors for opsonins. So opsonins are usually IgG and C3b. So these substances usually coat the microorganism. Suppose there was a bacteria, so IgG and C3b will coat this organism, and this will facilitate in phagocytosis. So the receptors for opsonins will identify this IgG and C3b coated microbes, and they will be easily recognized. So the next step I told was engulfment. Now the recognition had happened. What will happen? The phagocytic cell will form a cup-shaped invagination and engulf this entire bacteria. And inside the phagocytic cell, this engulfed structure is going to fuse with the lysosome, and it is going to form the phagolysosome. Okay, phagosome was formed, and then it was fusing with the lysosome, forming a phagolysosome. So inside the phagolysosome only, the intracellular killing is going to take place. So how does this intracellular killing take place? Again, it is by 3 mechanisms. First one by reactive oxygen species, then next one will be by nitric oxide, and third one will be by the lysosomal granules. So the first one, ROS, will be the most important mechanism. So reactive oxygen species is nothing but free radicals, right? So whenever this NADPH, there is an enzyme called as NADPH oxidase or phagocyte oxidase. It's also called as phagocyte oxidase. This enzyme will cause the conversion of NADPH to NADP, during which oxygen is converted into superoxide ion. So superoxide ion is a free radical, we all know that. So superoxide ion will then get converted into H2O2 with the help of superoxide dismutase enzyme, right? So superoxide dismutase converts the superoxide ion into H2O2. Then this H2O2 can either form hydroxyl ion with the help of Fenton's reaction, or this H2O2 with the help of an enzyme present in the neutrophils called as myeloperoxidase. So MPO enzyme and in the presence of a halide like chlorine, so it can form a very potent free radical, which is HOCl. So HOCl is formed. So this entire system wherein H2O2 MPO and this halide is being used up is called as the H2O2 MPO halide system. So this is a very potent antimicrobial system. So this process in which this NADPH oxidase is causing the formation of the superoxide is termed as the respiratory burst. So this happens inside the phagocytic cells like neutrophils and macrophages. Okay. So this HOCl which has formed is a potent free radical, and now it is going, since it is going to happen inside the lysosome only, this HOCl is going to attack the bacteria which is being engulfed and kill the bacteria. Okay. The next step of killing will be, the next other type of killing will be using nitric oxide. So this nitric oxide killing is more potent in the macrophages. So there is an enzyme called as nitric oxide synthase. There are three forms of this nitric oxide synthase. First one will be the eNOS, nNOS and iNOS. E stands for endothelium. So in eNOS form is present in the endothelium. N stands for neuronal. So nNOS is present in the neurons, while iNOS stands for inducible. So it is this inducible form of nitric oxide synthase which actually leads to the formation of a free radical called as peroxynitrate. So whenever nitric oxide is present, it will react with superoxide free radical in the presence of this iNOS enzyme and then form the peroxynitrate, which is again a free radical, and this free radical is going to kill the bacteria or whatever microorganism was ingested. The third step, the third type of killing will be with the help of the lysosomal enzymes. So we know the phagocytic cells are going to contain lots of granules, especially the neutrophils. So the neutrophils contain two types of granules. The primary granules, which are also called as the azurophilic granules, while the secondary granules are called as specific granules. So the primary granules are MPO, which is myeloperoxidase, which was involved in the MPO halide system, right? H2O2 MPO halide system. Then we have lysozyme, defensins, acid hydrolases, then proteases like elastase, cathepsin G, non-specific collagenase and proteinase 3. And in secondary granules or the specific granules, we have gelatinase, lactoferrin, histaminase, plasminogen activator, alkaline phosphatase, lysozyme again and collagenases. So all of these have very potent antimicrobial properties. So these granules which are present inside the lysozymes, these are going to destroy the engulfed bacteria. Okay. So now the removal is being done. So what happens? All the offending agents have been cleared. Now the cell, this inflammation has to be regulated. That is, it has to stop. So this step is this fourth R, which is regulation. So for regulation, we'll have to terminate this acute inflammation, right? So how does that happen? Once this offending agent is removed, automatically the stimulus which was causing this inflammation, that is the secretion of the inflammatory mediators, they will stop, and whatever stimulus was given, that is going to stop. So automatically inflammation will stop. Then the cells of acute inflammation, which were the neutrophils, they have a very short T-half, so of 6.5 hours only. So after that, the neutrophils will die. So again, the inflammation will stop. Then there will be anti-inflammatory mediators which are being secreted. So anti-inflammatory mediators like interleukin 10, interleukin 13, TGF-beta and interleukin 6. So these interleukins will be secreted, and these will cause the inflammation to stop. Then cholinergic discharge. There will be cholinergic discharge which is going to inhibit the TNF-alpha. TNF-alpha, I told, it is the major inflammatory mediator responsible for the cellular events, right? So TNF-alpha is going to be inhibited now by this cholinergic discharge. So regulation step is done. So what are the clinical aspects related to acute inflammation? So first one will be leukocyte addition defect. So addition is going to be defective. So addition was one of the cellular events, right? So addition was mediated by the integrins. So this is the higher affinity kind of interaction. So integrants, some kind of integrant defect is going to be there. So we have two types of LAD defects. Type 1 LAD is going to be the defect in the LFA1 and MAC1. So these were integrants present on the phagocytic cells, remember. So with the defect in the LFA1 and MAC1, addition cannot happen properly. So the clinically they will present with delayed umbilical cord shedding. So this is the classical history they will give, delayed umbilical cord shedding. They refer to the type 1 LAD. Then type 2 LAD, here there is a defect in the enzyme called as fucosyl transferase. This fucosyl transferase is the actually needed for the formation of silyl Lewis X. So there, with the defect in this enzyme, there is going to be absence of silyl Lewis X, which are actually needed by the P and E selectin. So this is the ligand for E and P selectin. So without this ligand for P and E selectin on the WBCs, again addition cannot happen. So again there is going to be addition defects. So all of these clinical syndromes are going to, clinical diseases are going to result in recurrent infections. So there will be a history of recurrent infections also. And specifically for type 2 LAD, they will give a Bombay blood group. So this fucosyl transferase is responsible for the blood group. So there will be no A antigen, no H antigen, no B antigen. So without A, B, H antigen, there is not going to be any kind of antigen present. So normally in a O blood group, if you see, there is going to be at least H antigen which is present. So only A and B will not be there in O group, but H antigen will still be present. But in Bombay blood group, even H antigen is going to be absent. And that it is important because for these patients you can transfuse only Bombay blood groups. Okay, no other blood group you can give to that patient. It will cause reaction. So second clinical disease will be an MPO deficiency. So MPO was a neutrophil azurophilic granule, right? So MPO is not there. So what will happen? This MPO halide H2O2 system cannot function properly. So that again result in recurrent infections. Thirdly, we have Shediac-Higashi syndrome. This syndrome, there is a defect in the LIST gene. So it is an autosomal recessive condition in which the LIST gene is defective. LIST gene is responsible for controlling the lysosomal trafficking inside the cell. So lysosomal trafficking is going to be defective. So the fusion between the phagosome and lysosome, the movement of the lysosome towards the phagosome is going to be defective. So defective fusion will result in defective phagocytosis, right? The clinical features of this syndrome will be some kind of granular defect will be there. So the first thing will be giant granules in the neutrophils. On peripheral smear, if you see, you are going to see lots of giant granules in the neutrophils. Secondly, albinism. The melanin granules are not going to be trafficked properly, and that will result in albinism. Thirdly, there will be defect in the transmission of the neurotransmitters and missile substance. So here there will be some nerve conduction, nerve defects. Then bleeding. So the platelets granules will also not be trafficked properly. So because of that, there is going to be bleeding disorders. So all kind of granule defects will be seen in this Shediac-Higashi syndrome. Next, we'll see about chronic granulomatous disease. So chronic granulomatous disease, here the defect is going to be in the phagocyte oxidase or the NADPH oxidase enzyme. So NADPH oxidase enzyme is defective. It could be either as a inherited as an X-linked disease or an autosomal recessive disease. X-linked disease is when there is a membranous component, when the membranous component of the NADPH oxidase enzyme is defective, while the cytoplasmic component, if it is defective, it will lead to the autosomal recessive pattern. So usually this NADPH oxidase is not a single enzyme. You have multiple components present on the membrane and the cytoplasm. So only when the phagocytic regulation takes place, all this NADPH oxidase is going to be recruited on the phagolysosome. Okay. That is when the next step of phagocytosis and the intracellular killing will start taking place. So in the X-linked disorder of this NADPH oxidase defect, it is the FOX stands for phagocyte oxidase, which is the other name for this NADPH oxidase. So the glycoprotein 91 of this FOX enzyme is going to be defective, while in the autosomal recessive condition, the P47 and P67 components of the FOX enzyme is going to be defective. So how do you test for these patients? In chronic granulomatous diseases, we can use a test called as nitro-blue tetrazolium test. So NBT test can be used. So normally this nitro-blue is going to be colorless. So only when there is a free radical, it is going to convert into formazine compound, which is going to have a blue color. This is the normalcy. However, in this chronic granulomatous disease, without this phagocyte oxidase, free radical, which is the HOCl, cannot be formed. So this NBT will remain colorless because it will not form formazine, which is the blue color, respond for the blue color. So if it is remaining colorless, it is indicative of chronic granulomatous disease. We have another test called as dihydrorhodamine test, which is kind of better and sensitive than that of a NBT test, because it is a quantitative test as well. We can quantitate the enzyme deficiency here. And it is going to be based on flow cytometry. It is a flow cytometry based test.